Welcome to Basic Gonioscopy. My name is Richard Lehrer. I am a glaucoma specialist in Ohio, Director of Glaucoma Services. I'm an assistant professor of ophthalmology at Northeast Ohio University of Medicine. Our course is Basic Gonioscopy, and gonioscopy is a very useful tool that you will use in the office on a daily basis. It will help you diagnose different types of glaucoma, recognize different types of glaucoma pathology, recognize different angle pathology, and also very useful in glaucoma surgical procedures. I would like to credit Lee Allen's drawings, which are used by permission of Dr. Alward at University of Iowa. Other drawings and images are courtesy of the AAO image collection. If we look at the anterior chamber angle, histologically, we see there are many structures involved in the anterior chamber angle. We know that the cornea is the most anterior and superficial structure, which is pictured on the upper right. Below that is the anterior chamber, below that the iris, and below that the lens. Where the cornea and iris come together, this is known as the anterior chamber angle. And there are a number of structures here which are very important to the health of the eye and identifiable in glaucoma. The anteriormost structure, abbreviated SHW, is Schwalbe's line. Posterior to that is trabecular meshwork. Next is scleral spur, and then the anterior chamber angle recess and the ciliary body face. And these are the basic structures that we'll be looking at. It's also important to remember what is peripheral to these structures and deep to these structures as we go through the anatomy of the eye. So really, it's important to think very anatomically as we go through this talk. Looking at another view, we see a very similar thing, this time facing the other way. We can see the anterior chamber angle centrally, slightly to the left. We can see a tubular structure, which is Schlemm's canal, here labeled sinus venous sclerae. There's trabecular tissue anterior to that, and trabecular meshwork anterior to that. You can see the scleral spur beneath Schlemm's canal inserting into the anterior chamber angle, and it's important to notice that the long muscles of the ciliary body, the longitudinal fibers, insert on the scleral spur, and they have a very specific action when they act on the scleral spur. Here's an H&E stain of an angle, and not all of these structures are readily apparent. If we look at the same sort of slide in trichrome staining, we can see much more easily in dark blue the scleral spur coming in from the right, inserting into the anterior chamber angle. Above it is the canal of Schlemm with some venous collector channels peripheral to that. Just central to the Schlemm's canal, we have juxtacanalicular tissue, and then trabecular meshwork, then the anterior chamber. Also notice in red on the bottom the longitudinal ciliary muscle fibers which insert on the scleral spur. When this muscle is activated, it actually pulls down on the scleral spur, and this helps open the trabecular meshwork, which can enhance flow of fluid out of the eye. Here's another drawing of what we can see gonioscopically. And this is sort of a 3D view with a side view as well. And what we can see in the asterisk, we're going to talk about in a little bit. That's where the anterior and posterior sides of edges of the light beam on the cornea come together. This is known as the corneal wedge, and it always terminates in Schwalbe's line. Schwalbe's line labeled number 6 here. C, B, and 5A, that's all part of the trabecular meshwork. and 5A is the pigmented and posterior portion of the trabecular meshwork. Number 4 is scleral spur, 3 ciliary body, and 2 ABC is the iris, the last roll of the iris. Here's another cartoon taken from scanning electron microscopy, and what we notice about the trabecular meshwork is that it's really sort of arranged in beams, and these beams are spongy. Deep to that is juxtacanalicular tissue, and then the inner and outer walls of Schlemm's canal. The scleral spur is embedded within part of the trabecular meshwork, and you can see the ciliary muscle again inserting on the scleral spur. What we're looking at here is a scanning electron micrograph, which is trabecular meshwork inserting into Schwalbe's line. Schwalbe's line is the anteriormost structure in the angle that we usually identify. It is the termination of Descemet's membrane. It is usually white with or without pigment. It is flat or very slightly elevated. If it is greatly elevated, this is a congenital condition called posterior embryotoxon, which can be part of several syndromes. Here's another depiction of the termination of Descemet's membrane, this transition zone to trabecular meshwork called Schwalbe's line, and corneal stroma peripheral to the corneal endothelium. Here's another scanning electron micrograph with corneal endothelium on the right, trabecular meshwork on the left, and this transition zone or Schwalbe's line running down the center of the slide. In this drawing, what we see is superiorly in the gonio image, we can see a wedge of light. We see a beam to the right, which is the inner beam of the slit lamp following along the endothelium. On the left, we see the light coming together in a wedge in a more diffuse, slightly hazy beam, and this is the light reflecting off of the anterior surface of the cornea and then following the corneal tissue to where it terminates at Schwalbe's line. Using this wedge is very, very helpful at defining Schwalbe's line, especially in eyes with ambiguous or very little pigmentation. Note the white line of Schwalbe's line. If you follow the arrow to the left, you can see a drawing of the histologic section that corresponds with this, and Schwalbe's line is indeed the termination of cornea. The dotted line going up represents that line where the corneal tissue is clear, inserting to the limbus as it moves toward the surface of the eye to the left. And that corresponds with that hazy white line that we're seeing in the image. Trabecular meshwork beneath Schwalbe's line, you can see, is very minimally pigmented, and if we didn't have this wedge, we might be confused as to where Schwalbe's line really is. In this image or series of images on the left, we can see what the angle looks like with diffuse illumination, and we can see a little bump in the iris, but by tightening our beam and focusing our beam on that bump in that area, we can see that that is really a drawn-up area of iris with an iris process leading to Schwalbe's line. How do we know that that's Schwalbe's line? Well, look in the image rightmost on the screen, and that in that image you can see the wedge, and where the wedges come together of light, that is always Schwalbe's line. Here's another image where we can see trabecular meshwork a little bit more pigmented, and notice that the pigment in this case is deep, but Schwalbe's line always will follow that wedge. We can see the wedge superiorly, and this corresponds with the drawing on the left. In this image, where there is almost no pigmentation of the trabecular meshwork, it is extremely difficult to find landmarks for lasering unless we use the corneal wedge. In this case, the wedge is rather faint, but we can see it coming in from the bottom left of the image on the right, and where the wedge comes together is a line, and that is Schwalbe's line. Unfortunately, while we're looking at patients, we don't have histologic drawings next to us, but we have to think about things histologically and try to understand where we're looking at a structure when we're looking at it en face. Another image, this time through one of the nasal or temporal mirrors of the gonio lens, and in this case you can see Schwalbe's line, which is the termination again of cornea, identified by the wedge. Trabecular meshwork is the next structure that we encounter when we go posterior to Schwalbe's line. This appears roughened. There are trabecular beams with what look like pores. It is usually gray-white to semi-transparent and has a varying amount of pigment. The pigment is usually most posterior, where the outflow through the trabecular meshwork is the greatest. If we look at this image, we can see an image of trabecular meshwork where there is very little pigmentation, and we don't have the corneal wedge in this case to help us, but luckily we have a nice anatomic drawing next to us. We can see that the trabecular meshwork in this case is light gray, almost bluish looking. In this case, we see a brownish band of pigmentation identifying trabecular meshwork. And how do we know it's trabecular meshwork? Well, look back at the wedge. We see the wedge superiorly in the image, which is identifying Schwalbe's line for us, and the next structure posterior to that is trabecular meshwork. The next white line posterior to that is scleral spur. Notice about the pigmentation in trabecular meshwork that it's very, very smooth, and this is because this represents very fine granules of pigment, which are often seen in conditions like pigment dispersion syndrome. Notice that the pigment in the drawing on the left is very deep within the trabecular meshwork and juxtacanalicular tissues. Again, this is because these are very, very fine granules of pigment. In this image, we see a very different type of pigmentation. This pigmentation is much more lumpy and bumpy and clumpy. It is not as regular, it's not as smooth, and this means that the pigment granules are much, much larger. And as you can see from the drawing on the left, which is taken from an actual histologic section, the pigment is really trapped on the interior surface of the trabecular meshwork and not deep within the trabecular meshwork and juxtacanalicular tissue. This is much more common in syndromes like iris chafing and pseudoexfoliative glaucoma. Here's another case where we have more lumpy pigment, a little bit smaller, but notice that the pigment is not identifying trabecular meshwork. If you just quickly looked and did not use your wedge, you might laser the wrong part of your eye, incorrectly identifying this pigment band as trabecular meshwork. But using the wedge, you can clearly see that this pigmentation is on Schwalbe's line and slightly posterior to it, while the trabecular meshwork is somewhat more posterior. Here's a case of extremely heavy pigmentation, and in this case this is more typical of pseudoexfoliation syndrome. You can see that the pigment is very lumpy and bumpy. There's even a pigmented line anterior to Schwalbe's line. This is called a Sampolizi line. You can see it's irregular in contour, irregular in pigmentation, and there is diffuse other pigmentation around the angle, including Schwalbe's line and the posterior aspect of trabecular meshwork. Again, if you looked only quickly at this angle and tried to laser this patient in argon laser trabeculoplasty, you might laser the wrong spot if you weren't very careful here. Here's a photograph of a patient with pseudoexfoliation syndrome and a Sampolizi line, and we see something very similar to what we saw in the previous diagram and drawing. In this case, we have diffuse, rather dense pigmentation all across the trabecular meshwork, crossing over scleral spur into ciliary body, crossing over Schwalbe's line, and there is a faint Zampalese line as well. In this case, we have very little pigmentation, but we see some faint iris processes on small blood vessels leading up from the angle. These do not appear grossly pathological, as they are not fine and branching, but rather radial and straight. The trabecular meshwork, to be noted in this case, is very, very lightly pigmented, and we don't even see Schwalbe's line because we are not using a wedge. The canal of Schlemm is peripheral to trabecular meshwork. It is a tubular structure, approximately 190 to 350 microns in diameter. It is usually not seen on gonioscopy unless it's filled with blood. In order to fill the canal with blood yourself, you can do this with indentation gonioscopy. Trauma can cause blood in Schlemm's canal, and increased episcleral venous pressure from a number of syndromes can cause blood in Schlemm's canal. Here's a drawing with blood in Schlemm's canal, and it should be noted that Schlemm's canal is not necessarily a uniform diameter throughout, but it can vary in size. We have also recently learned that there are pumps within Schlemm's canal and a number of tubular processes, and these exit into pores which lead into the venous collector system. The canal of Schlemm is usually contiguous 360 degrees around the eye, but in some cases it can be discontinuous. In order to indent Schlemm's canal, you need a flanged gonio lens, and by applying gentle pressure near the mirror where you are looking, you can see that blood can reflux into Schlemm's canal. Scleral spur is the insertion of the sclera into the angle. It is usually white to yellow in color, slightly elevated, and attached to the longitudinal ciliary muscle. As you can see in the drawing on the left, the longitudinal muscle fibers are black and oblong, and they insert into the ciliary body and into the scleral spur. By action of the longitudinal muscle contraction, the scleral spur is pulled posteriorly, and this can open the trabecular meshwork. In the image on the right, you can see a whitish band where scleral spur is represented. We know that this is scleral spur and not Schwalbe's line because of the corneal wedge. The corneal wedge most inferior in the picture depicts the Schwalbe's line junction, and the next line posterior to that is scleral spur. Here's a case where scleral spur appears to be somewhat yellowish and a little more broad. And here's a case where scleral spur is almost unidentifiable, but we know that it's at the anterior junction of the ciliary band. How do we know that this structure is where it is? Well, again, look at the wedge superiorly, identifying Schwalbe's line as the faint white line in the upper portion of the image. The next white line is Schwalbe's line. The ciliary body band or face is seen on gonioscopy. It can be gray-white to yellow to brown. Pigmentation can vary tremendously, as individuals' pigmentation can vary. However, the person's skin pigmentation does not always correlate with the ciliary body pigmentation. As you have learned or will learn soon, there are many metabolic and physiologic functions of the ciliary body. The ciliary body in this image is seen to be somewhat lavender or grayish in appearance with a tinge of brown. In this case, the ciliary body is brown and a little bit variegated, And what we're seeing is that we only see part of the ciliary body face. The remainder of the ciliary body face is blocked by the role of peripheral iris in its way. We will learn about a few techniques about how to see around this roll into that sulcus in the angle. In this case, the ciliary band is broad and dark brown in pigmentation, fairly uniform. We should be aware of pathologic conditions such as angle recession, and it's often important to compare one eye to the other eye, especially after a trauma, in order to try to determine whether or not an angle recession has occurred. This will be covered in a little bit more detail in the pathologic section of gonioscopy. The iris and root of the iris inserts on the ciliary body. The last roll may obscure the ciliary face or ciliary band. We want to note the shape and color and configuration of the iris. We want to note iris processes. These are iris stromal extensions and usually extend to scleral spur or trabecular meshwork, occasionally extending to Schwalbe's line. Here's an example where you can see an angle recess, which on the left appears to be open. However, gonioscopically, if we look at this image, it appears to be closed. That's because the last roll of the iris is blocking the view into the angle. In this case, we see a number of iris processes extending from the iris to the scleral spur and trabecular meshwork. In this case, we see some pigmented iris processes. Again, these are not pathologic. They are fairly regular and uniform. When we think about the peripheral iris, we must think about two conditions: appositional angle closure and plateau iris, as these conditions may present occludable angles which can cause great elevations in pressure and cause disc damage. Angle blood vessels can also be seen. These are usually radial. Occasionally we will see looping vessels or portions of the major arterial circle. Pathologic vessels, in contrast, are fine branching. They generally will cross the scleral spur and can be associated with the fibrous membrane. Once neovascularization in an eye is treated, regression of these vessels may occur and the fibrous membrane may still be present. This can lead to elevated intraocular pressure without necessarily seeing the presence of vessels. In this case, we see some normal appearing angle vessels. They are fine, they are not really branching, and occasionally only do they cross the scleral spur. In this case, again, we see some very fine, regular appearing vessels in the angle. These do not cross the scleral spur. In this photograph, we see a patient with neovascularization due to a central vein occlusion, and in this case, the blood vessels branch significantly. They are irregular. They move and look like tree branches. They are very fine, and they cross scleral spur, trabecular meshwork, and even cross the Schwalbe's line. Here's a photograph of a bay in St. John, and we were thinking anatomically, what does this look like? It sure looks a lot like iris and ciliary body. Always think about anatomy. It's important to review gonioscopy and the history of gonioscopy, as this is very helpful in understanding how we got to be where we are today with it. Alexios Tranthis is the father of gonioscopy. He was the first to examine the angle in 1907 and was a Greek ophthalmologist. When we look at an eye from the side, normally we can't see into the anterior chamber angle. Why is this? In certain animals, they have a different configuration in the front of the eye, and oftentimes we can see into the anterior chamber angle. The reason that we can't see in a normal eye is because all of the light from the angle is internally reflected into the eye at the tear-air interface. By changing that angle in conditions such as keratoconus, we can directly view the angle structures. However, in a normal eye, it requires some other method to look into the angle. Direct gonioscopy was the first technique using a lens to change that angle. This is a Kepi lens, and with a Kepi lens you can see a direct, large, wide-angle view of the angle. It's achieved by using an external illuminating source and an external microscope in order to look at the angles. Angles can be viewed simultaneously from one eye to the other, and this technique is still used by many pediatric ophthalmologists to examine the angles of babies. This is a Kepi lens. A modified Swan-Jacob surgical lens is much more commonly used these days, and with many of the newer angle procedures which have followed goniotomy, we have things on the lower right like trabectome and eye stents which regularly employ angle surgery, and in order to do this type of angle surgery, we must be able to view the angle and correctly identify all of the angle structures. Indirect gonioscopy is most commonly used by most ophthalmologists in the office. With an indirect gonio lens, we're using a mirror or a prism in order to direct the light from the angle across the cornea into the viewing area where we can see what's going on. A Goldmann 3-mirror lens is commonly available with or without a flange. This is a rich trabeculoplasty lens used by many for argon laser trabeculoplasty. An SLT lens designed by Mark Latina for selective laser trabeculoplasty. A Zeiss 4-mirror lens. These are not commonly available anymore. With this lens and very low magnification, we can sometimes see all 4 aspects of the angle with one view. The Posner lens is the lens that I prefer to use. It has a number of different handle styles depending on your preference. The other advantage of the Posner lens is that only tear film or anesthetic is required to couple the lens. It does not require a coupling agent such as methylcellulose. A Sussman lens is also available, similar to the Posner lens, but does not have a handle, and this may be a little bit more difficult for tilting the lens during gonioscopy or a little more difficult for indentation gonioscopy. Let's talk a little bit about performing gonioscopy and what residents and physicians can do in the office to make gonioscopy easier. Often this is a very stressful time for new residents learning gonioscopy. It's important not to make gonioscopy an ordeal. Gonioscopy should be very routine and part of your examination, and you should always have your gonio lens readily available, able to use at any moment while doing a slit lamp exam. It's important for the patient to be seated comfortably with their chin in the chin rest, forehead against the strap, and you will notice on most slit lamps there is a bar to the right or left with a black line. That black line is for alignment of the lateral canthus. If you have the patient's lateral canthus aligned with this black line, you will almost always have adequate excursion up and down in order to be able to achieve full gonioscopy in all mirrors. It's important for the examiner to be comfortable. You should be comfortable. You should have your elbow resting on the table of the slit lamp, and if your elbow doesn't reach, use an elbow rest or a lens case. This is very helpful at steadying your arm while you're performing gonioscopy. Your fingers or the backs of your fingers can rest against the patient's cheek while you're holding the lens by the handle with 2 other fingers. You can even use other fingers to help hold the eyelid open while you are examining the patient with a gonio lens. This does take a little bit more practice. It is most comfortable for the patient if you insert the lens with the flat edge of the lens parallel to the lid. That way you're not indenting the lid with the corner of the lens, which can be a little bit uncomfortable. If needed, the lens can then be twisted in order to see further around the angle. This is a typical view that we might see in a patient with moderate pigmentation using our gonio lens. In order to look into a shallow angle, or an angle that has obscuration from the last roll of the iris, we can have the patient look towards the mirror that's in use, or we can tilt the lens toward the mirror that is in use. And this can help us see into that recess and overcome any blockage from the iris obscuring our view of the angle. Darkroom gonioscopy, compression gonioscopy, and dynamic gonioscopy are very useful techniques, especially when evaluating an angle that is more on the narrow side or where we are concerned about the possibility of adhesions or peripheral anterior synechia. In darkroom gonioscopy, it's important to keep the room lights extremely dim. We want to use a short, thin slit beam. We want to keep the beam out of the pupillary axis and use this to evaluate the angles. In this way, we can tell very much so that an angle may be prone to occlusion in dim lighting and therefore at risk of angle closure attack. This is an ultrasound biomicroscopic image of an eye. And what we see in this image is that an eye in bright light on the upper portion of the image has a broad, flat iris with an open angle. The same eye in very dim illumination has a much more compact iris. We can see a change in the volume of the iris, where the iris has become much thicker as the pupil dilates, and we can see a narrowing of the angle. This can be observed gonioscopically as well. Compression gonioscopy can be used also to evaluate narrow angles, but it's necessary to use a prism that does not have a flange, such as the Posner, Sussman, or Zeiss lens. Ambient lights, again, should be dim or bright. We should use a short, thin slit beam and keep it out of the pupillary axis. And we want to evaluate the angles with and without gentle posterior compression. If you are seeing significant wrinkling in the cornea in your image, you're pushing too hard. This is good for evaluating anterior synechia, or PAS, and plateau iris. In this diagram, we can see in the upper image, without compression, the angle appears almost completely closed, and with compression on the left, the angle opens, but on the right, the synechia are preventing the angle from opening. In this image, in the upper portion, the angle looks closed without compression, and with compression, the angle is entirely open. In this image, the upper image looks identical to the prior one, completely closed, but with compression, what we find is that the left-hand portion of the angle is entirely open, and the right-hand portion of the angle is entirely closed due to the presence of anterior synechia. These are photographs depicting the same thing: upper portion without compression, lower with compression, and on the left-hand side the angle opens, on the right-hand side the angle does not. In dynamic gonioscopy, what we are doing is varying the light as we observe the angle gonioscopically. Again, we want to use a gonioprism, but this time with or without a flange. Ambient lights must be very, very dim. We want to use a long, thin slit beam initially, keeping the beam out of the pupillary axis, and we want to evaluate the angles while suddenly and significantly increasing the slit beam. We want to observe changes in angle width and angle structures that are visible. I would very highly recommend that you go to this website, gonioscopy.org. It's been put up by Dr. Alward at University of Iowa. He has written a number of textbooks on gonioscopy. This shows techniques and techniques for difficult angles. It has excellent videos, excellent photographs, and excellent explanations. And I think we are all indebted to Dr. Alward for providing us with this valuable tool in learning gonioscopy. So the question is, how do we communicate to our colleagues when we look at an angle? How open is an angle? Is it open? Is it closed? Is it narrow? Is it in between? Is it grade 1? Is it grade 4? And what do all these grades mean to us? There are a number of angle grading systems: von Herrick, Scheie, Schaefer, Spaeth, and it's important that we know how to record the results for our charts and for communication with our colleagues. We want to judge anterior chamber depth, and grossly we can do this with a pen light, just to look at the shadow of the iris when we shine the beam of a pen light across the eye. This is useful for our technicians in helping to decide whether or not to dilate a patient before we see them, or whether we ought to see the patient first. With the Van Herrick method, a slit lamp is required. We use a dark room. We put the slit beam at 60 degrees, and we measure the anterior chamber versus the corneal thickness near the limbus. A grade 4 Van Herrick angle has an anterior chamber depth which is greater than 1 corneal thickness, and a grade 1 angle has a depth less than 1/4 corneal thickness. If we look at this slide, the image on the left, we can see the space between the light and the iris is the anterior chamber, and we can see this is larger than the thickness of the cornea using the same beam. That translates to grade 4. On the right, we see just a slit of dark between the cornea and the iris. That is a grade slit, and generally this is an occludable angle. When I was in residency 20 years ago, we were taught that Van Herrick was only for use by optometrists and not really very accurate in predicting whether or not an angle was occludable. However, recent well-controlled studies have been done and show that Van Herrick estimation of angle is a useful tool at predicting angle closure. The Scheie system was then publicized next, and Scheie's system graded the angle from wide open wide, slightly narrowed 1, to angle completely not visible, grade 4. He also graded pigmentation similarly, from none to grade 4. The Schaefer system was opposite. Note, Scheie's system was Roman numerals, Schaefer's system is Arabic numerals, and in the Schaefer system, a grade 4 angle is wide open. Most people in the United States use the Schaefer system when describing an angle, and when they talk about a grade 4 open angle, they are talking about the Schaefer system. In the Schaefer system, a grade 1 angle is extremely narrow, and a slit-like angle is narrowed to a slit. Grade 1 and slit are at high risk for angle closure attack. Here's a diagram of a 20-degree angle versus a 45-degree angle, and this is something that requires a lot of practice and mentoring. It is important to have someone with you when you are doing your first 20 or 30 gonioscopies to help you estimate angles, because it does take a while to really get the hang of what an angle looks like, since we don't always have a cross-section and we're looking at the angle en face. Here's again a wide open angle. This angle looks like it's about 45 degrees open, and it is quite wide. Here's another bay in St. John, which again looks a lot like an iris and ciliary body. Think about the anatomy. That pool over there could be Schlemm's canal. Spade's classification was designed to try to be a little bit more descriptive about the angle than the Schaefer system. In the Spade system, not only do we grade the level of iris insertion as A, Schwalbe's line, B, trabecular meshwork, C, scleral spur, D, ciliary body, and E, iris root, but we also measure degrees in the Spade system, and these are degrees between an artificial plane drawn from the peripheral iris to the peripheral cornea. We also note the angle configuration and the iris configuration. The old system on the left, S, Q, and R. The new system on the right, B, P, F, and C. B is for bowed anteriorly, P for plateau iris, F for a flat iris, and C a concave iris. And we can see this in this chart. Iris insertion, graded from A to E, angular approach from 0 to 50, peripheral iris, flat bowed, plateau, concave, and then we grade pigmentation of trabecular meshwork. So in Spade's classification system, this angle would be a C in parentheses next to D, 30B. The parentheses are in order to help us differentiate compression versus non-compression gonioscopy. What is seen without compression is within parentheses, and what is seen with compression is next to the parentheses. So without compression in this angle we can see scleral spur. With compression we can see ciliary body. We believe this angle is open about 30 degrees, and the configuration is bowed anteriorly. To record gonioscopy, one can use this type of chart called a Becker goniogram. Most of us tend to use an X in the chart, and this is the way I learned it from my mentors, Gary Condon, who learned from Dick Simmons, who learned from Morton Grant. Basically, we label the X as right eye or left eye. We label each quadrant of the X as to what we can see with and without compression, just as in the Spade system. We note whether or not there is pigmentation, whether there are iris processes, whether or not there are anterior synechia, and what the angle degrees are. This is very useful for communicating with colleagues who may be a little bit confused as to which gonioscopic grading system we are using. I will thank you very much for your attention and be happy to answer any questions by email as outlined in the course series. Thank you again. I hope this was useful for you.